Hello, my name is Michelle Zechner. My pronouns are she, her. I'm faculty at Rutgers School of Health Professions at the Department of Psychiatric Rehabilitation and Counseling Professions. I've been helping people living with mental health conditions and their families for over 20 years. One of my passions is learning about new services to help people recover from mental health issues. Welcome to Mind Care Matters, a podcast series dedicated to exploring new and innovative strategies to improve mental health. Today, I'm so delighted to be talking with my colleague, Dr. Anthony Zazzarino, or Dr. Z, as his students like to call him. Dr. Zazzarino, who uses he, him pronouns, is an assistant professor at Rutgers University in the Department of Psychiatric Rehabilitation and Counseling Professions, where he is the assistant program director for the MS and PhD programs and the field experience coordinator for the counselor education and supervision track. Dr. Zazzarino has published extensively and offers workforce development on affectational and gender identity, multiculturalism, psychiatric rehabilitation methods, counseling services, substance use disorders, housing, and supervision practices. Dr. Zazzarino maintains a private counseling practice focused on adolescents and adults in New Jersey. Welcome, Anthony.
Thank you. Thank you so much for having me today.
Oh, great. Well, I'm so glad you're here. We've been planning this for months, so I'm so excited that we finally got time to sit down and talk together. Today, we're going to be talking about mental health services, serious mental health conditions, and the LGBTQIA plus community. So, Anthony, start us out. Tell us a little bit about this topic and things that we need to know.
So first off, I just want to thank you and thank the listeners for being open to learning more about this population. I think this is a very unique population in the fact that it is one that's growing and evolving every single day. So what I will say, if there is something that I mentioned today that others and viewers and listeners might not think is the most appropriate language, I will apologize. And I will say that I'm also still learning, which is exactly what I want just people in the community and practitioners to do, just to learn and be open to learn and be open to even making some mistakes, because I think that's how we grow. And that, really at the core of it, we have to go back to just listening and validating these unique experiences, which I know we'll talk a lot about more. But then I think the other part of that is not overly pathologizing one's affectional or gender identity, because though that may be a reason that they come in and they're receiving services, it might not be the only reason. And I think we have to be mindful about that.
That's a strong introduction, Anthony. I really appreciate you saying that. And the idea of listening and validating is something that we do in mental health often. We often try to offer person-centered care, but I think what you're sort of hinting at, and I know I've struggled with a little bit in the realm of mental health, is I don't necessarily have the experience of being in the LGBTQI plus community. I want to be a good ally, but I don't necessarily know, and I feel like I'm going to make mistakes.
I think that's a lot of people's fear is, I don't want to say the wrong thing. And so by default, we say nothing. And I think what's more important is continuing to learn. And if you say the wrong thing, being humble and apologizing and thanking the person for correcting you, and then moving on with a lesson learned.
Yeah, that's really powerful. Listening is just humility is sometimes a challenge for me, I think for many of us, but yeah, listening and apologizing. Sorry, go ahead.
Dr. Zechner, I would say that I, even as a member of the LGBTQ plus community, I don't know everything, and I still struggle. And I think that part of it is what keeps me wanting to continue to learn and continue to grow, because we don't know everything, even for members in the community.
Thank you, Anthony. That really makes me feel better. Well, what do you think? So we've started off with just listen and be with the person and don't pathologize their experience, which I think is really a great kind of foundation. What are some of the other kinds of basics that mental health providers should be aware of that are issues in about mental health in LGBTQ plus community?
So that's a really great question and something I've thought about for a while. And I think one of the biggest things is, and I know we use, and we'll probably continue to use the acronym LGBTQ plus today. And I think the reason for using it is it makes it a little bit easier. But I think sometimes using that acronym, we then tend to see and view everybody under that acronym as one, when in fact they are really two very different subsets of populations, right? So we're looking at affectional identity, which I could talk about in a little bit, right? But also known as, a lot of times people will know it as sexual identity, but then also gender identity. So I think one of the basics is recognizing that they're very two different groups of people that have very different experiences. And so we can't look at that whole umbrella of LGBTQ plus as one.
And that's really helpful to, again, go back to our roots in mental health, to sort of say, providing person-centered care really means listening to the person and what their experiences are. But you're saying maybe even take it the next level and assume that we don't know much without asking the person.
Well, yeah, I think even in mental health, when we talk to people, just even about anxiety, right? And we ask those follow-up questions. Okay, well, what is that anxiety like for you? I think the same thing is true when we're talking about gender identity and affectional identity, right? Asking that follow-up question, like, okay, well, how important and what does that mean to you? So that we don't assume and so that we get the individual's unique experience and we get to really empathize a little bit more from that perspective.
Yeah, yeah. Thank you so much for that clarification. I would love to hear from you. And unfortunately, I don't know, and maybe you know that there's a lot. I think the research kind of lumps people together. Where you were just talking about like not lumping people, and
Yeah.
yet we, when I ask you to sort of think about some of the research out there, can you talk a little bit about what you've seen or know?
Yeah, I can. And I think the research is definitely evolving and changing, just like with every topic. But I think we are still seeing a lot of researchers researching the LGBTQ plus experience. And I think that really does hinder the types of services and the evidence-based services that we could provide, because I don't think we actually fully understand the needs of affectional identity individuals and affectionally diverse individuals, I'll say, and gender diverse individuals. So I think right now, as an educator, as a practitioner, and as a researcher, I think what we know we have to take with a grain of salt, but I think we have to start somewhere, which is where I think we've been. I think a lot of the research is shifting to start to look at these two separate groups of people. But what we know right now, based on research of the LGBTQ plus community as a whole, that they do experience much higher rates of mental health conditions. Part of that is, related to anxiety and depression. We also see that they are 2 to 3 times more likely to attempt suicide. And I
Mm.
know September was National Suicide Prevention Month, and I think that was a really important time to really shed the light on this population. Substance use rates are higher, HIV rates are still higher, and so we have all of these statistics that show that this is such a vulnerable population, and yet people are less likely to receive services. And I think that's, for a myriad of reasons, and we can touch on them a little bit more. But I think this is a really important population to work towards getting into services.
Yeah, it sounds like there's a lot going on. And I've been reading and attending this part of my professional CEU requirements about LGBTQ plus adolescents and
Mm.
the super high risk for self-harm and really sort of as a population being so at risk that even we did some work last week on 988, the 988 helpline,
Mhm.
and they have a new line that's dedicated to LGBTQ plus youth. So I think that's really a great step in the right direction.
Well, yeah, and then also like we're talking about affectional and gender diverse individuals, but then we also have to include all of the other intersecting identities that, the population experiences and the layers upon layers of different minority stresses that can really impact that person. And we can't look at somebody in a silo. We have to view them as a whole person. And I think that also then impacts their mental health and some of the services.
Oh, that's so powerful. Yeah, there's that word that's often uh, talked about now in mental health called intersectionality, which is
Yeah.
sort of where people may identify in a number of different ways. Maybe someone from a historically marginalized population, maybe in the LGBTQ plus community. And then I do a lot of aging work. And then someone's also an older adult. And then they have a lot of this kind of stuff that sort of leans on them. And that can really impact people's lives, their experience of discrimination, stigma, poverty, a lot of different things.
Yeah.
So there's a lot to consider here, isn't there, really?
There is a lot to consider, but again, I think it just goes back to the basics. It's just about, creating um, that safe and trusting environment. It's about using language that's empowering and strengths focused. So the reason that we are starting to shift to the term affectional identity is because really when we look at that word sexual identity, it really immediately goes to the idea of sex, right? And it begins to sexualize the attraction where it's much more than just sex, right? And that word affectional identity is all about that romantic, that emotional, that spiritual connection. And so we're starting to see that language shift. And again, it just goes back to the basics, I think. And as a practitioner, as a helper, as an ally, it's just about being with another individual in a safe, trusting environment.
Thank you, Anthony. That's really helpful to try to really build that sense of safety and trust. And can I ask you, I'm going to be totally ignorant. I'm trying to be humble here, modeling that. But for affectational identity, are you really kind of referring to someone who identifies as male, maybe attracted or want to be in a relationship with another identifying male or an identifying female or a non-binary person? Or am I getting that
So,
right?
yeah, so affectional identity, you can look at it in terms of what used to be called sexual orientation, right? Like gay, lesbian, bisexual, pansexual, and the list can go on and on. But that's really what we're looking to gravitate to, if that's
Okay.
helpful.
Thank you.
You're
Thank you.
welcome.
Yeah.
And see, I think asking questions like that, is really helpful just to get clarity. So thank you
Hmm.
for asking.
Well, so I work a lot with people with serious mental health conditions, and I would love to know your thoughts about people in the LGBTQ plus community who also experience serious mental health conditions. What can you tell us about that population?
Yeah, I'm glad that we are talking about that because I think this is often a population within the LGBTQ plus community that gets often overlooked. I don't think we know much about this population because I don't think as people, I don't think we even begin to ask the questions, right? And I think we tend to just assume asexuality and cisgender that we just assume that the people that we work with are asexual and cisgender. And I think that a lot of times that comes from systemic issues. Even if you look at documents for like federal government grants, we're still stuck in a more binary uh, language of male and female related to gender. But I don't think we ask enough. I don't think we ask enough because we assume. I think, sometimes we fear that if we push that topic, we might increase someone's symptoms, or we might unlock something that we're not really ready to handle. But I don't think we know that much because we're afraid to ask, and we assume a lot. I think the other thing, though, that's really important is even if we do ask, I think we might not get the full truth, because within a state hospital setting and within the population of individuals with serious mental health conditions, individuals that are coming out as affectionately diverse or gender diverse tend to be much greater victims of violence. So, it's, a twofold issue there. Even if I do ask, the person might not want to share, because if they do share, they're more prone to being discriminated against, violence, and just hate from not only other peers, but sadly, other practitioners in that setting. So
Yeah.
it's a really difficult topic and situation, but it's definitely something we need to keep pushing towards and working towards.
Yeah, and I think you brought up state hospitals, and I've certainly seen that in the consulting that I've done. But it's probably also true in other outpatient settings, like, outpatient services or intensive outpatient, or what we have in New Jersey, partial hospitalization, or other mental health settings may not be welcoming, I think,
Yeah.
to put it another way.
Yeah, I think even in, the most least restrictive in terms of housing, right? When people are living integrated in the community, it's still not a topic that is fully addressed. And even within that setting, especially if people are living in apartments with other individuals, that the ability to be their full self is not there due to fear of that victimization. And I mean, that internalized, if you're not open, right? If you're not comfortable being who you are, you then tend to suppress and internalize all of that. And what we see is that really is the greatest correlation to the substance use, the suicidal behavior. So it becomes really tricky and really, an important topic to focus on.
Yeah, yeah, and I could really see how creating, as a mental health provider, is creating a culture of safety,
Mm.
really trying to create a welcoming environment so that people feel like they can be their true, authentic selves and express themselves however they want, is actually really therapeutic in a way.
Yeah, it absolutely is therapeutic. And we have to also remember, especially working with individuals who are aging, which is going to be a large population of aging individuals that identify as affectional gender diverse. The history of homosexuality and of gender dysphoria, of being a pathologized diagnosis, is not that long ago. I think it was, sometimes in the DSM-3 that homosexuality was still a mental health diagnosis. And currently, even though we just had the update of the DSM-5 TR, gender dysphoria is still a diagnosable mental health issue. So again, you have a population who needs uh, additional services, but then also don't feel safe attending those services. And, we can't overlook that piece of it.
Yeah, yeah. Well, I think we have to, as mental health providers, we do need to learn more, and we need to think about how we create safe spaces, and
Yeah.
what we can do. And this is our first foray into learning more. I would love to know what your thoughts are about the current trends in this topic, and what do you think is going to be happening in the world of mental health and LGBTQ plus communities?
Yeah, I think, this touches on something I mentioned earlier. I think you're seeing a lot of research really being done on the two distinct groups separately. And I think that is a really, really big step, so we can truly understand what it is for the needs of individuals that do identify as affectionally diverse versus those that identify as gender diverse. Even looking at interventions that are more strength-based. And we talked about language, right? Language shifting to more empowering, strength-based language. I think that's really where the trends are going to be moving forward in the research, which will then help practice a little bit better. Yeah, I think that's where we're seeing.
Among my friends, they have told me that one thing that makes their experience with people better is asking for pronouns. And that seems like a small ask, but it seems like it's something that can make a difference for someone to feel seen and heard and their identity valued.
Yeah, I mean, absolutely. And I was just actually looking the other day, and even on the Office of Disease Prevention and Health Prevention, when you look up LGBT evidence-based resources, again, they're giving you resources for that whole umbrella term and not really giving you those unique individualized experiences. So, there's some that they'll say they're evidence-based interventions out there. I would just say take them with a grain of salt. We always have to question research anyway. So I think it's understanding, what we can take from that.
Hmm. Hmm. Yeah, that it's still kind of a young field of research in a
Yeah.
way. Yeah. Well, so how can someone learn more about the topic if we want to go out there and really dig into the research and clinical practice? What should we do?
Yeah, I think a lot of it is becoming an active learner. I think we all have to go out and seek those webinars, seek the research, keep reading. For me, as a licensed professional counselor, I and a member of the American Counseling Association division of SAGE, which which stands for the Society for Sexual, Affectional, Intersex, and Gender Expansive Identities. I know they're doing some great work. They do conferences, they have webinars on their website. They're even in the development of what's called a rainbow certification, which will be a set of classes that counselors can take in order to say, hey, I have done this extra work to become a more educated and knowledgeable counselor to work with this population. There's also, there's many great resources. SAMHSA has a lot of great resources, and I know SAMHSA has the Center of Excellence for LGBTQ individuals that they offer. So I think it's just being an active learner. I think it is recognizing that we are not perfect and that we will make mistakes, and that's okay. Just like we don't ask for perfection in our clients, we cannot expect perfection for ourselves. So being humble, being ready to apologize if we do make a mistake, but just continuing to go out there and be an active learner. And sorry, don't feel awkward wanting to just have conversations with people in the community to learn from them.
Yeah, no, that's a great suggestion too. Just having conversations and being open and being culturally humble in this way as well. If you just don't know what someone's experience is like, and just asking them and in a way to just learn more about them. Thank you for sharing those resources, and we will put those in our show notes in the blog. We have sort of a list of resources that people can click on. So, any final last words that you'd like to offer us, Anthony?
Just be open to learning and don't be afraid. Continue to create safe spaces, and keep doing the great work that you're doing. And I just want to thank you, Dr. Zechner, for having me and for having this conversation. And hopefully, listeners can take something positive away from it.
Thank you, Anthony. And thank you, everyone, for listening to this new episode. It's really been eye-opening and a pleasure to have this conversation. Excuse me. This podcast is a production of the Northeast and Caribbean Mental Health Technology Transfer Center at Rutgers University and made possible by funding from the Substance Abuse and Mental Health Services Administration.